Sorry, thank you. Hi, my name is Adele Soutar. I am a third-year internal medicine resident down in Wilmington, North Carolina. I wanted to talk about a pelvic hematoma that we saw after a UroLift procedure in our medical ICU. So for introduction, the UroLift procedure is a minimally invasive option to treat lower urinary tract symptoms secondary to BPH. It's shown to have a very strong safety profile, especially compared to the TURPs. Well over 250,000 patients have been treated with the UroLift procedure since 2021. Complications are not well known. It is a newer procedure. Thus, there have been at least 28 cases of pelvic hematomas reported since 2015, and 3 reported in the literature, not including our case. So today we present a case report of a patient who underwent a UroLift procedure and developed a pelvic hematoma of the bilateral internal iliac arteries within 24 hours of the procedure itself. So our case is an 85-year-old male with a past medical history of mild dysplastic syndrome, hereditary hemochromatosis, hypertension, hyperlipidemia, and a right subacute MCA infarct in the past, and BPH, who presented to the ED with hypotension, weakness, nausea, vomiting, and 2 episodes of loose stool. He previously underwent a UroLift procedure earlier that morning and became profoundly weak, altered, incoherent at home, and his wife checked his blood pressure and found it to be 60/40, which prompted them to call EMS. When he arrived to the ED, this was about 15 hours after he had that procedure, and they gave him immediate IV fluids to help improve his hypotension, which he was responsive to. He was also found to have an elevated lactic to 11.9, he had an AKI. He also had a significantly low bicarb of 16, and he had a bit of a white count of 24. Hemoglobin was found to be 5.4 at that point. Baseline was normal for him. They did do a CT renal stone protocol since he had this recent procedure, and he was having some abdominal pain with that as well. But they actually found a large mesenteric hematoma with extravasation from the internal iliac artery. So for his management, he got great access to 2 large bore IVs. He also got centrifugal access as well. Since his hemoglobin was quite low, they gave him immediately 2 units to get him up to 7, which he actually corrected to 8. They called the IR team, and he was transferred to the ICU for further monitoring because he was hypotensive, had the lactic, and had this large bleed on imaging. He did happen to have worsening vitals. He was more tachycardic. He had worsening hypotension, which they increased his pressors, prompting them to give another liter of fluids immediately to stabilize him, while they were able to get some platelets and another unit of blood as well for him. Since he did have a white count initially when he presented to about 25, and he did have some bandemia to 42%, he possibly could have had sepsis as well with this presentation of hemorrhagic shock. And he had a procedure that day, so they did cover him broadly with vancomycin and Flagyl just to make sure that they weren't missing any infection as well for him. Since IR was consulted and we had a source on imaging, he did undergo a geofoam embolization of a branch of the internal iliac artery, the left one, which they saw, and then they actually did the bilateral internal iliacs as well after the procedure when they found bleeding from both. So they repeated his hemoglobin, and it was down to 6.3. So we got another unit of blood as well. So he's up to about 4 for this hospitalization total. And they also gave him a unit of cryo. His hemoglobin and hematocrit were trended every 4 hours just to make sure he was stable. But he also had found to have C. diff since he initially had that complaint of having diarrhea as well, some loose stools. So he was treated with vancomycin for 10 days as well for him, pulled off the other antibiotics since there wasn't any other source identified as well. Once he was stable and off any sort of pressor support, he was transferred to the floor and did have some rehab following his hospitalization. So overall, UroLift procedure is common and very safe for symptomatic BPH, but pelvic hematoma is rare, but a serious complication and a possibility of the UroLift procedures, as we saw in our patient as well. And just overall, since our patient did get both volume and blood, volume is great for acute stabilization, or at least to improve the blood pressure immediately, but ultimately blood, especially in the setting of hemorrhagic shock, is the best resuscitated fluid. for the patients. Any questions?
Can you kind of talk about the downsides or the cons of the UroLift procedure, and how can we kind of avoid those complications?
Yeah, so I talked with the urologist who performed the UroLift on this gentleman just to see what his thoughts were and why he did have this complication. So he was saying that normally when they dislodge the stents in the UroLift, it'll hit the pelvic bone. But some patients have just different anatomy where the bone isn't protecting any vasculature. And so when the stents dislodge, they do happen to hit more commonly the iliac arteries. And so that's what happened with our patient. There isn't really a predictability as far as whether that would or wouldn't happen in the patient, but it's just to be of note that that is a possibility, and just to sort of educate the patients on what to look out for and what to monitor after the procedure, especially since it is routinely done outpatient. So that's kind of the main complication, in addition to any other procedural complications that come routinely.
So you said it usually is done outpatient. Are there cases done inpatient?
I'm not as familiar with the procedure to know if it is done inpatient as well. It might be if someone is severely symptomatic or has other reasons to be admitted inpatient. But to my knowledge, his was done outpatient, and that's kind of my limited exposure to it. So.
Okay, great.